So this first session today is about the basics of addictive disease. The way that I've tried to design this is some of the new science on addiction is very high-class science. They use huge words. And most people, even counseling clinicians, don't normally use those kind of words. So what I try to do with this session is take the current science and not dumb it down, but put it in language that is usable with the general population of clients and family members and the public as a whole. So I'm going to begin with the concept of who is it that uses drugs? Who becomes an addict? There are four basic types of addiction that develop. The first one is what we call simple addiction. Simple addiction develops like this. At some point in a person's life, they begin drinking or drug taking. And the reason a person begins drinking or drug taking in the experimental stage is because young people like to experiment with things. Now, the average age for experimenting with alcohol and other drugs outside of the family system, okay, this is not drinking wine with Thanksgiving dinner, but sneaking the drinks outside of the family system. The average age in New Jersey is 7th grade. Okay, so that's when the experimentation begins. Now with simple addiction, the reason the person experiments, in the third session we'll get more into detail on this, the reason the person begins to experiment is out of curiosity. But as time goes on, more regular use takes place and it eventually develops into chemical dependency or addiction. Now, in the early stages, the reason the person continues using is because it provides a good feeling. Now, we don't like to hear that concept. We like to hear drug abuse is bad, drug abuse is evil, all the stigmatizing language that our culture uses. But the reality is the reason most people start and then continue is because it feels good. Now, if the person uses on a regular basis over a long enough period of time, the physical addiction develops. And along with the physical addiction, physical problems start to develop. Now, the most common physiological secondary effect of substance abuse is malnutrition, because you stop eating properly. You stop exercising. So the secondary physical effects of drug abuse, or drug use even, is that it's going to have negative physical impact. As time goes on, the physical addiction develops. Now the physical addiction, the time and the amount is going to vary from person to person. Let's use alcohol as an example. In New Jersey, the average time for the average person to be admitted to detox for the first time is around 45. On average, that person has been drinking regularly or even daily for as much as 10 years before the first detox experience. What we can assume from that is it takes about 10 years to develop the physiological addiction to the drug alcohol. Now that's the average. Now, if a 15-year-old drinks at the same rate as that 45-year-old, it only takes 18 months to develop the addiction. If a 65-year-old drinks at the same rate as the 45-year-old, it only takes about 12 months to develop the physical addiction. So the take home on that is, if you're going to start drinking heavily, wait till you're 45 because you'll last longer, okay? So the concept there is that the age of our body has something to do with the rate at which our addiction will develop, okay? Now, at the same time, oh, but by the way, every drug develops the addiction at a different rate. Opiates, for example, if you take an opiate for 10 days in a row, you're starting to develop a physiological dependency to the drug. Okay? Most patients that are in orthopedic units at hospitals, they don't know it, but they've begun to develop a physiological addiction to a drug. Okay? They don't know it because by the time they're treated properly in the orthopedic unit, when it's time to go home, they've reduced the amount of the opiate and they've been given a take-home that's only going to last a little while, so they don't even know they were addicted. Okay? Addicted is probably not even the best word. They were dependent on the opiate for a period of time. By the time they're home and back to work, they're not using anymore. Okay? So opiates kind of work like that. Side comment. Whenever you're treating a patient for chemical dependency, if they have a history of alcoholism or opiate use specifically, they must know that if they're going to go in for surgery anytime in the future, 20 years of recovery, anytime in the future, the anesthesiologist needs to know that they have a history of alcohol or opiate addiction. And the reason is the drugs that they use to put you under, to anesthetize you for surgery, if a person has a history of the addiction, the anesthesiologist is going to have to use more of the drug to put you under. Consequently, if the anesthesiologist does not know that and gives you the average amount, and hold on to your seats, you may wake up during surgery. And many of the reports of people waking up during surgery and then trying to sue the hospital for not doing it properly, it's because there was a history of alcohol or opiate use that the anesthesiologist was not informed about. Because a lot of patients think, okay, if I haven't used in 20 years, if I haven't used in 10 years, it doesn't make any difference. So rather than enter into the stigma of being an addict, I will just tell the anesthesiologist, no, there's no history. But they need to know that there is, okay? And that's all part of the physiological addiction that takes place. Now, at the same time that the physiological addiction is taking place with the simple addict, we also have the psychological addiction developing. And along with the psychological addiction, psychological problems. Now, this pattern of the simple addict, of going from drug use to drug dependency and addiction, and the psychological addiction, this will develop up to a point that we can call chronic addiction. Now, the important thing about simple addiction is it's called simple or primary addiction, and it's called that because the addiction effects are a direct result of the drinking or drug taking. Okay. Take away the drinking or drugging, in about 10 to 15 days, the physiological addiction is pretty much dealt with. You don't need the drug anymore. Given 3 to 6 months of abstinence and recovery, so it's not just not using, it's getting into a good physiological lifestyle, good diet, nutrition, and exercise, getting into a good emotional lifestyle, learning how to deal with stress, anxieties, relationships, and that sort of thing. Getting into a good social lifestyle, which means developing a peer group of supportive friends and family. The psychological addictions don't necessarily go away, but they are now able to be controlled by the individual. Okay. Now, how long does all of that take? We look at the new DSM, and after 2 years of sustained recovery, we see this concept coming out of sustained full recovery. And sustained full recovery is the closest we're ever going to come to the word cure, at least in this time in history. So 2 years of continuous recovery. The first couple months, very intensive, very often inpatient, residential, IOP. The psychological addiction takes a good 6 months or more to get that under control. And they're the phases when professional counseling is going to be most important. That second year is usually done with peer self-help groups. So if a person gets into that self-help model of recovery, 12-step recovery is the most common, but there's also some alternatives out there for people that have a problem with the God word. They can get into that kind of recovery, and if they can maintain the abstinence experience for about 2 years, that's considered as good as we can get. Okay. Now, do people relapse after 2 years? Yes. But the reality is most people can get it in 2 years, maybe with more relapses in the beginning as part of the disease process. So the full process of recovery is going to be about 2 years. In that third phase, when we're dealing with self-help groups, we have good research started with the VA and has been used in a lot of medical programs. And among the programs that were used was the program that I work for in New Jersey, the Professional Assistance Program. We treat medical professionals. So we treat physicians, dentists, pharmacists, nurses, those kind of folks. And what we have found from national surveys in this population is that in that maintenance phase, if they're attending 3 meetings a week, the probability for long-term recovery is up around 85–90%. 2 meetings a week is around 50%. 1 meeting a week is around 35%. So having somebody just go to 1 meeting a week when they first get out of treatment is probably not enough. AA, in its wisdom early on, started talking about 90 meetings in 90 days. And that was to get people hooked on AA, to develop kind of a positive addiction to AA. And that's where that long-term recovery comes from. But remembering that with the simpler primary addict, the drinking or the drugging is the main issue. So you can cut the person off the drugs, get into the good physical, emotional, social lifestyle, and everything else works out normally. Okay? So that's one kind of addiction. Next kind of addiction is a term that has changed over the years faster than I can get. So since I'm old, I will still use the old terminology. Dual diagnosis. Okay, dual diagnosis, co-occurring. It started out being called double trouble. Okay, and this concept of treating co-occurring diseases began in Monmouth County, New Jersey. Okay. It began with a group of people that were working at Marlborough State Hospital, psychiatric hospital, and they were treating a lot of addicted people. There was a group there which consisted of a psychiatrist, a social worker, and 2 nurses that were all in recovery. And what they would do, they would meet for lunch every day as a small recovery group, dealing with all these psychiatric systems and staff. And they would discuss the problems with their patients. And what they saw was that people that came in with 2 diagnoses, the chemical dependent people, when they got out of treatment, they went to their AA or NA meeting and they were told, don't take any medication. The psych patients, or the psych diagnosis, needed to take the medication. So the patients were put in this untenable position where treating one disease was harmful for the other. So they decided there was a need for a special kind of 12-step group that would not tell them not to use. Because all too often, when psych patients were told not to use their prescribed medication, they would go back into depression, they would go back into other mental illness, and end up dying. So they needed this new kind of group, and they started the first double trouble groups back there, which evolved into co-occurring groups. So this second kind of a group is what I call dual diagnosis. And dual diagnosis develops like this. Very similar to the simple addict. At some point, the drinking or drug taking begins. The drinking or drug taking begins at the same age as the person who develops a simple addiction, because that's the culture in which they live. When they start using, however, something different happens. You see, this patient also has a psychiatric illness. Now, when this person began using, the reason they continued was because it felt good. When this patient began using, they found out, when I use this drug, I no longer feel the psychiatric pain. So it's not to feel good, it's to feel well, feel normal. The problem is they come down off the high and the psychiatric problem comes back, and they now start a process of self-medication. And this process of self-medication continues to build upon itself. In that case, the psychological addiction develops very quickly, because none of us likes emotional pain. And if the person is using on a regular basis over a long enough period of time, the physical addiction develops. And at that point, as that continues, it all develops up to the same point of chronic addiction. And at the point of chronic addiction, we can't tell the difference between the simple and the duly diagnosed patient, because we got the same symptoms. Got the drinking and the drugging, psychological addiction, psychological problems, physical addiction, physical problems. So with the simple addict, you take the drug out of the system, and they start getting better as recovery takes place. With the duly diagnosed patient, you take the drug out of the system, and what happens is the psychiatric problem now surfaces. Okay? When I was working down Straight and Narrow, my apartment was right upstairs from the detox. So in the middle of the night, when we got somebody brought in, that was a problem. Besides the nurse, I was the only one in the building that had any semblance of authority. So I would get called down. One of the things that I noticed over the years, and this matches up with what the science says today, when we had somebody coming in for alcohol detox, after 2 or 3 days, the simple addict started to look and sound better and better and better, healthier and healthier and healthier. What we eventually identified as a duly diagnosed patient, once we started detoxing them after 2 or 3 days, they started behaving crazier and crazier and crazier. Okay, that is not the way to officially diagnose anybody. Don't misinterpret this. But on a very practical level, that's the easiest way to tell early on whether you've got a psychiatric problems that's co-occurring with the addiction versus a primary addict. Okay? So that pattern continues up to the same point of chronic addiction. At that point, we can't tell the difference between the two. Okay? Now, in the handout, I've got a definition there for you. And I like to, the reason I like to print it out is because when I rattle this off, people try to write it down too quickly and they miss everything. So don't try to write this down. But here's the principle about the addicted personality. Depending on your clinical training, what background you were trained in terms of psychology, social work, and all that, you may been given the concept of the addictive personality theory. The addictive personality theory, primarily in psychology and some groups of social work. This was a philosophy or a theory that said that everybody's got some kind of addiction that develops in their early life and progresses into adulthood. And the addiction, this personality structure, is what causes the drug abuse. Okay? That has been disproven by just about everybody. Some groups of psychologists are still holding on to it, mostly the analytical group. Addiction psychology has thrown it away. They follow the addiction model. But the principle is this: it's not the personality that leads to addiction, but what we have is the addicted personality. It's not pre-existing the addiction, but the personality shows itself after the addiction has developed. So the addiction develops up to a point that we reach chronic addiction. So here's a personality profile. Listen to it from any patients that you've ever treated, from any addicted people that you've known in the past, or think of it in your own life if you've had some of this experience. So addicted persons are asocial, inadequate, immature, and unstable. They're selfish and self-centered without any interest in the welfare of others. They're only concerned about their own problems. Their major problem is in the maintenance of their addiction or the immediate gratification of their desire for the object of their addiction. They lack self-discipline, willpower, and ambition. They avoid responsibility. They resort to any means, however unreasonable or dangerous, to satisfy the craving. They fail to develop normal human relationships, and they do all of this without any concern for the pain they inflict on their relatives and friends. Okay? That's the end result of addiction. Now, there's a little bit of a problem in our culture today because what other personality sounds like that? Adolescent personalities in our culture. Adolescent personalities in other cultures do not sound like that. Adolescents in many other cultures around the world are maturing. But American culture, which by the way is the place where the term adolescent began, because everybody else went from child to adult right away, but American culture starts spreading it out, and we got this new group in there of adolescents, and this personality profile is very similar to adolescents. So we then run into the additional problem. We have a group of people whose personality profiles are similar to that of an addict, and then we get them using mood-altering drugs on a regular basis. They're sitting ducks for addiction in our culture. Okay, so that's an important thing to understand, and especially if you're dealing with families, okay, because this is part of it. Now, there's two other types of people that use drugs and abuse drugs. One is what I call symptomatic. by the way, if you're preparing to take the national exams, this concept is not on the exam. The concept of primary addiction and dual diagnosis is on the exam. This is my favorite because it's very elusive and complicating. Here's a population that it looks very similar to that of dual diagnosis. Person starts using a drug at about the same age as everybody else. But unlike the dually diagnosed, instead of a psychiatric diagnosis, there's a psychological issue. Now, let me use a stereotype here. Emphasize stereotype. You have a middle school boy. It's getting to be time to start dating. The kid is extremely shy. His psychological issue is extreme shyness. He's afraid to ask somebody out on a date. However, he finds out, give me a couple beers and I'll ask anybody out on a date. And they do. The beer wears off. He's now socializing with his peers, and the peers say, it's pretty good. He went out and he got a date and all this sort of thing. So the next time it's time to get a date, a couple shots. So a very similar thing to dual diagnosis, except you're dealing with your fears and phobias to get over it. Here's the difference between symptomatic, simple, and dually diagnosed. This person will frequently grow out of the problem. Okay? Now, we started to see this when vets were coming back from Vietnam. I mentioned this to a graduate class one day, and one of my grad students put their hand up and said, oh yeah, my grandfather told me about that. So that made my aging issues more intense. Okay. So for you folks, looks like you might remember Vietnam. Okay. So soldiers were coming back from Vietnam, and in Vietnam, the use and abuse of chemicals was extremely high. Many people would say that in Vietnam, a very high percentage were either physically and or psychologically dependent on alcohol or other drugs. Okay. When they came back, Vietnam vets tended to fit into one of three categories. About a third of them continued to use and became primary addicts. Another third continued to use, and the psychological issues became psychiatric diagnoses. The third group, their feet landed on the mainland, and they just never used again. Now, in the research, they call it spontaneous remission. But this is a case where people who were using addictively without treatment would just stop. But it's only 1/3. Now, I'm very careful when I do this with adolescents, primarily because you say to an adolescent, you have a 1/3 chance of not becoming an addict. That's all they need. So that's not a good thing. But the reality is we need to be careful in diagnosing someone chemically dependent during adolescence, because we got to look a little more intently at the social environment that they're in. It's not simply chemical dependency. So this group, symptomatic use, the important thing about symptomatic is they don't cross into chronic addiction just from symptomatic use. They either go into dual diagnosis, into simple addiction, or they just stop. Okay? Now, not to give away secrets, but remember your first year of college, if you lived on campus? At Seton Hall, anyway, we made pyramids out of beer cans. Anybody remember pyramids out of beer cans? That sounds alcoholic. It's not. That's just first year of college drinking. Okay? Most people stopped making pyramids out of beer cans as they matured, usually by the time of senior year. Okay? But most people that went to college, the first year, there's a lot more drinking and drugging than they had before, but you mature out of it, and that's that third that is important there. Now, where this is a problem for stigma in our society is a third of those people say, this is no disease, I just stopped willpower, okay? But that's a third of one small part of a population. The other 2/3 of that population got formally diagnosed, either primary or simple addiction or dual diagnosis. Okay. The third group is the group that I call medically induced. This is relatively new, and over the past 10 years, 10, 15 years, we've had major changes in how we understood this. For a long time, until relatively recently, we were being told that if you need pain treatment, that you can use addictive drugs, but so long as it's only the certain dosage to take care of the pain. And we're seeing the horrible results of that today, and it's been shown in court that this was a manipulation of information from the pharmaceutical companies. Okay? So what they were originally saying, that even people with addiction histories could safely use narcotics for pain, we now don't hold that. Okay? There was a period of time when the science was telling us this could be done. Now, in treating physicians, what we learned was that, yes, there were some that were able to do that. But in retrospect, the ones that were able to do it successfully were the ones who maintained a good 12-step connection. They kept a sponsor. They got some additional counseling during the process leading up to the surgery and post-surgery. They were doing all the other recovery stuff needed. But people that were just using the medication just as medication, these were the people who were running into problems. So these folks started off with the physiological pain, using the drug to get rid of the pain, and without any kind of formal counseling or treatment, the psychological addiction continued, and along with the psychological addiction, the psychological problems, and that we now see can also turn into chronic addiction. Okay. Now, two of the terms that I've used a couple times here, there's a difference between physiological addiction and psychological addiction. Physiological addiction is when the chemical makes a change in the body chemistry at the cellular level. Okay. Now, physiological addiction, you can begin to treat in 5 to 10 days. You can get it under some pretty safe control. And that's why our detox programs usually run about that long. Okay? That's enough for a person to get physiologically back in control of their behavior. Psychological addiction is not an addiction to the drug. Okay? Physical addiction is an addiction to the drug, to the chemical. Psychological addiction is not an addiction to the drug. Psychological addiction is an addiction to the effect of the drug. So the person is hooked not on the drug, but on the euphoria that goes along as a result of it. Psychological addiction takes 1 to 2 years of recovery to get that under good control. And that's why it's important that people get more treatment beyond just withdrawal management, beyond detox. Okay? In fact, many of us these days, and this is a national trend, medical withdrawal management, detox, that's not even considered treatment for addiction anymore. That's pre-treatment. You got to get the chemical out of the system in order to begin treatment. Okay? So in ASAM, a lot of us are saying, yeah, this is different. You know, yes, there's a treatment plan. Yes, there's medical treatment, but it's only treatment for the physiological aspect of the disease. That detox by itself, if we just detox a person, no further treatment, it's less than 10% recovery rates because they will just keep relapsing. Okay? You take withdrawal management detox with residential or IOP for about 6 months, your recovery rates jump up to around 33%. Put in that another year or two of either formal treatment or self-help treatment, and addiction treatment has actual success rates of up around 85–90% recovery if they maintain the treatment plan for that period of time. Now you ask most people on the street, how many people recover from addiction? They're still talking about 10%. You ask judges, they'll say, oh, just 10%. Because what they're seeing is the relapsing of the people that are only being detoxed. Because people think so long as I get it out of my system, I'm cured. And that's just not the case. There has to be the extended treatment. Okay? So the physiological treatment is part of it, but the psychological treatment is a major part of the long-term recovery process. And part of that psychological treatment is the social and spiritual aspects, most of which are formalized in the 12-step recovery process. Okay? So if this person were to continue, even with prescriptions, they still become addicted, chronically addicted. Okay? What we also know about pain is we used to think that the pain medications took away the pain. But what we now know about narcotics is once you become physically dependent upon them, the narcotic creates its own pain, which is different than the pain that they first used to get rid of. So that down here, initially the drug was used to get rid of pain. Once the addiction begins to develop, the narcotic use becomes its own pain. And then you have to use it to not feel sick. Okay?
Or what means?
Alumni groups are a good way to help with the maintenance. Alumni groups provide a similar service that we see with 12-step groups. It's a peer recovery type thing. And alumni groups are good. What I see the shortcoming of is the alumni groups are centered around a treatment program. Somebody moves to Philadelphia from North Jersey, the alumni group is not really that connected. Whereas if they get connected to an international network of 12-step folks, then they can go any place and kind of connect. So I think the 12-step programs and other long-term recovery programs are a better avenue than just the alumni. That being said, I think the alumni groups are really important. Back in the day, when I was there, we used to have annual dinner dances for alumni and their family. We'd get hundreds of people coming, you know, and that was families who had gone to family therapy together. That was clients that have gone together, that have been treated together. And for them to come back once a year, and this was the fascinating thing, all dressed up to the hilt. Now some of you may not remember this. There was a day when guys getting dressed up would wear suits and ties. They would dress up in suits and ties, and they would feel good about themselves, and everybody would see how good they're doing, and they would have their jobs, and they'd be talking about their jobs. And that is just a great builder of recovery capital. Okay, so we want to be able to do that. And the problem with the 10% business, since so many people think that detox by itself is all the treatment that they need, and government funding reinforces that, and insurance companies reinforce it by saying, we'll fund the detox, but all that talk stuff we're not going to fund. That's what keeps people from going into further recovery. You know, so again, we've got good statistics that show that detox by itself means 90% relapse rate. And that 90% relapse rate with just detox, that's what makes stigma, because the culture believes that. Okay, so we need to kind of get around that. Let's look at what motivates people in the treatment. Okay, most of you have been taught and used the model of motivational interviewing as getting people into treatment and recovery. Okay, and that is the current model, that is the standard of care. There is an older model which is not used as much anymore. Let me tell you the original model that was used. It was called negative motivation. Negative motivation began like this. You start off with pain. You go into treatment in order to get relief. Okay? You got a toothache, you go to the dentist to get relief. You got appendicitis, you get some surgery to get relief. This is a celibate speaking now. You have marriage problems, you go to therapy to get relief. I don't know anything about that. Okay? So that's the way most pain gets dealt with in our culture. Chemical addictions are the opposite. And also many of the psychiatric diagnoses are the opposite. You start off with the relief. You start off with the euphoria from the drug. You go into treatment to put up with the pain of everyday living. There is no logical reason for an addict to want to go to treatment because it's going to hurt. Okay? And this was the case that we've had for so long. This was the model. And the way we used to describe it is you had to hit rock bottom before you could get well. And that was true for a lot of patients. And in the early days, that was the only model we had. Okay? Now, we've got this new model of motivational interviewing where you start working with the person where they're at. Okay? Now, this is almost embarrassing, but this is ancient history. Back in the day, when I was down there, when people were coming into long-term treatment, and that's in the days when Dismas House was 12 to 18 months, they would have to convince us that they wanted to come into treatment. And there were people who we would say, well, you really don't sound motivated enough. Why don't you go back to county jail for a couple weeks and come back and talk to us later? Because we didn't think they were ready. Okay? Now, it's embarrassing to say this, but that's the way the whole system worked at the time. So we were telling people that they had to see themselves as sicker than they were in order to start getting well. Where'd we get that? Early AA. When AA first began, especially in the 40s, when different parts of the countries had different models of how it was being implemented. On the West Coast, the model developed like this. There were these clandestine groups of AA members. It was very difficult to find out where they were. But if somebody wanted to join, the way it worked was the group would pick 3 members to meet with the potential member and interview them. And once the interview was over, that 3-person group would meet and vote as to whether we were going to let this person into the group. That's where the tradition in AA began of telling your story. Okay? But in those days, out on the West Coast, some people would want to get into AA, but they didn't hit bottom enough to convince the 3 interviewers that they were ready to join. So they would sometimes tell the applicant, come back in 3 months, try again. And usually by that time the disease was getting worse, and now they were able to get in. But that's the way AA developed on the West Coast. And that's part of where this concept was coming from. So when you have the relief, the euphoria from the drug, and you go to treatment in order to put up with pain of everyday living, how do you get somebody to choose treatment? And the way it works, and we found this out initially from employee assistance programs, secondly from probation departments. You give them an alternative that is more negative than treatment. Either you go into treatment or you lose your job. Either you go into treatment or you go to jail. Either you go into treatment or you lose your kids. You go into treatment or this, that, or the other thing. So the negative motivation became the primary model to get people into treatment. Okay? Now, I'm an outlier on this. I still think there's a place for this model. I think if you've got somebody whose addiction is so bad that they're on the verge of death, motivational interviewing is not the way to go. With motivational interviewing, well, where do you think you're at? Oh, I'm fine, I don't have a problem. Well, when somebody is literally falling apart physically, emotionally, socially, and runs the risk of death and overdose, you may need to resort back to the older model of saying either you go into treatment or something worse is going to happen. Okay. Now, interesting statistics on motivation. If you have a group of people who are forced into treatment versus those who voluntarily enter treatment, who does better? Forced? Equal. Because if we can get them into decent treatment for 90 days, the brain starts clearing out, and those that were forced into treatment now are thinking more clearly, and they are motivated just as well as people who voluntarily went into treatment. And you will hear this from patients all the time. I hear it from my physician patients. Well, I entered the program voluntarily. Well, yeah, but you're still practicing medicine, so you're going to do what you're told to do. You got to do it the way the protocol is set up for monitoring. So it doesn't matter whether you're forced in by the medical board or voluntarily coming into the program, the recovery process is the same. If somebody goes in, and I'll use this example with them, if you go into treatment because your lungs are full of cancer and the doctor says, if you don't get the lungs taken care of, you're going to die, or if you self-diagnose as a physician your COPD as getting so bad that you know you need treatment, when you voluntarily go to the lung doc, you're going to get the same treatment plan as the person that was forced in. It's the same thing with addiction. Okay? So there's a tendency on some people to think, if I voluntarily go, I don't need as much treatment. You need the same quality treatment. And quality treatment is what we call a full treatment experience. You get through withdrawal, you do intensive rehab, which can be the inpatient or IOP, and then some outpatient, and then maintenance for 2 years. Everybody needs the same treatment. Okay. So now with motivational interviewing, we're now taking them where they're at and all that sort of thing, which basically means we're not telling people to stay away from treatment until you get worse. Okay, so that's good. Okay, we want to be able to accept people where they're at. I have a few private patients. I will work with them sometimes when I really think they're still using way too much. But I want to use that therapeutic relationship to build, because it's the relationship that's important, to be able to get them to the point where they start recognizing where the chemical use is now detrimental to their own health. Okay. But if I get somebody who's shooting up on a daily basis, I don't want to say to them, how do you feel about shooting up? I feel great when I shoot up. You know, that doesn't help me. When I was first starting at Straight and Narrow as an intern in '69, Dr. George Gubar was our psychologist. And at that time, he was the only psychologist in the state of New Jersey publicly working with addictions. No other psychologist was willing to do it. He was teaching at Seton Hall, and he was working at Straight and Narrow. And when I first got there, he would kind of joke with me a lot. And he would say, oh, you know, all you goody two-shoe types, you know, all you clergy types, you think that talking to people about how bad drug abuse is going to make them stop. He says, I thought that before I started working here. And then, being a psychologist, he started trying to research a little bit. And interviewing our clients, he tried to get what is the closest analogy to the rush from injecting heroin. And he said the closest analogy he was able to come up with was sexual orgasm to the 100th degree. And then he would say to me, and you're going around to schools telling kids, don't do this because it's bad. He says, I wonder why they don't listen. Because the experience of the drug use is a better experience than what they're getting in their daily lives. And that's why they continue. So trying to scare them out of it doesn't work. So we never had the scare straight concept going on at Straight and Narrow. It was always about becoming healthier. Okay? So basic pharmacology. This is real helpful, not only with clients, but with family members. Because family members do not get they don't understand anything about pharmacology. So the example that I'm going to use is Valium, a benzodiazepam. The reason I'm going to use Valium as an example is Valium's half-life is 23 hours. So this is the way half-life works. Half-life is the amount of time it takes for half of the drug to get out of the system. So on day 1, we take our 1 Valium. On day 2, half of that Valium is out of your system, which means that the other half is still in your system. On day 3, half of that is out of your system. On day 4, half of that is out of your system. And on day 5, half of that is out of your system. So when you take one Valium, that's the way that works. Let's say your prescription for Valium, which is never like this, is 1 Valium a day. Usually it's several a day. So on day 2, we take our 1 Valium. On day 3, we take our 1 Valium. On day 4, we take our 1 Valium. And on day 5, we take our 1 Valium. By day number 5, you now have in your system the equivalent of 2 Valium. And that's just with taking 1 a day. Now, most prescriptions are take 3 or 4 a day for 30 days. So you can kind of see where this is going. Most people taking drugs think, I take a drug, I feel good for a half hour, and it's gone. It's not the way it works. Every drug has a different half-life. The only person that I know of who knows what that is your local pharmacist. Okay? As you get experience in looking this stuff up, you may find that you got a better handle on what you can say. I always use Valium as the main example because that 23-hour half-life you can talk about a day. Okay? So here we have this natural buildup, and remember, this is not addiction. This is just regular drug use, legitimate drug use. Okay? So on day 6, and this was the case, a very famous case in our diocese with Karen Ann Quinlan. Anybody know the name besides Charlie?
What was that?
Karen Ann Quinlan?
I heard the name.
Oh, okay. She was the big right to life case. And she was working with Father Trapasso from our diocese as the pastor and the family. When she was first got into coma, there was a rumor going around that she was a drug addict. Family was very, very strong in saying, no, she was not a drug addict. Okay? And the reality was she wasn't. But she was being treated for depression. Now, here's the storyline. She was being treated for depression, and in those days, the only 2 medications for depression were Valium and Librium. So she was taking her Valium as prescribed. She knew she was going to a party. And on the side of the bottle, it says, do not drink alcohol when taking this medication. And she was following the rules of the medication. But she knew she was going to a party, so the day before the party, she stopped taking her medication because she knew she was probably going to be drinking. So on day 6, even though there's no Valium going into the system, there's still Valium in the system. And whenever we mix 2 drugs together, 2 mood-altering drugs, well, not even just 2 drugs together, one of 3 things will happen. One is called the additive effect. The additive effect of mixing 2 drugs together. You take 1 dose of drug A plus 1 dose of drug B, and you get 2. Okay? Alcohol gets you this high. Heroin gets you that high. Take them together, you get that high. Additive effect. Negating effect. You take 1 dose of drug A plus 1 dose of drug B, and they cancel each other out. Okay? Common misunderstandings about this. If I'm drunk on alcohol, which is a sedative drug, I can drink a lot of coffee, which is a stimulant, and that will straighten me out, sober me up. That's not what happens. What happens is part of your brain's going in this direction, the other part of your brain's going in that direction. The only thing you get when you give an intoxicated person with alcohol a lot of coffee, you end up with a wide awake drunk. That's the person who gets in a car accident. When you've got somebody who's drunk and wants to drive, don't give them coffee, give them another drink. Make them pass out so they don't drive. You give them too much coffee, they're going to start wanting to drive, get into a fight to get the keys to drive, and that's a problem. There's another version of that same myth. If I'm using a lot of Coke, which is a stimulant, and then I want to bring it down, I drink a lot of alcohol. Doesn't work. Part of the brain's going this way, part of the brain's going that way. Here's something, and I've never done this on tape before, so let me say I have a Protestant seminary degree and a Catholic seminary degree. I am a priest of the diocese, but I'm claiming this as part of my Protestant training. There are certain brands of birth control pills, because we Catholics do not deal with that at all, but for you Protestants that are watching. Certain brands of birth control pills, when taken with high doses of calcium, has a negating effect. So think about this. Certain brands of birth control, of which I am not familiar with any brand names, you got to talk to your pharmacist. Certain brands of birth control pills, if you're taking high doses of calcium, why do women take calcium? For the bone health, to try to prevent or treat osteoporosis. If you get somebody who's taking a birth control pill, maybe they're getting older in life, and they're taking high doses of calcium, one plus one equals 3. Okay, you didn't get that. Mom and dad equals a baby. Boy, you know, you guys are very Catholic apparently, because you missed that one altogether. Okay, so you got to be careful about mixing medications, even if it's not mood-altering drugs. You got to know that whenever you're taking a pharmaceutical drug, you got to know everything that can counteract the work of the drug. Okay, so that's a negating a drug. What's the drug that does best for us today? Narcan. Has anybody seen Narcan work? Has anybody ever seen it administered? First time I saw it, I went crazy. I couldn't believe it. Okay. Somebody's unconscious with overdose from opiate. They're given the Narcan, and they wake up clear as a bell right away. That's a really good example of negating effect. Okay? It takes the effect of the overdose of the narcotic, you put the Narcan into the system, it negates the overdose. Okay, absolutely amazing. And that's a good example of that. Now, today you're going to hear a lot of people talk about how Narcan doesn't work. Because, you know, we gave them Narcan and 2 hours later they were overdosed again and we had to take them in again and do it. The reason that's the case is because until very recently, there was a limit on the dosage for Narcan. And when Narcan was first put out there, it was based on heroin and normal opiates. Now with fentanyl mixed in everything, that one dose of Narcan is not enough to get somebody fully out of the overdose from a fentanyl-related overdose. So you now have to give extra doses of Narcan right away, or else they go into withdrawal again, use again, and then overdose the second time. Law enforcement hasn't understood this yet. Courts haven't understood it. A lot of the radio media hasn't understood it, so they're blaming it on Narcan not being good. It's because the fentanyl needs more Narcan than heroin does. Okay, so that's part of that current pharmacology. Now the third effect, which is what happens with Valium and alcohol, is called synergistic effect. Synergistic effect works like this. You take one dose of drug A plus one dose of drug B, and it multiplies. It's like 1 + 1 = 15. Okay? This is what happened with Betty Ford. This is what happened with Karen Ann Quinlan. This is what happened with Liz Taylor. This is what happens with a lot of the movie folks. Because the Valium is very available prescription-wise. The alcohol is very available with no prescription. You put them together, the synergistic effect is the alcohol gets you this high, the Valium gets you that high. You put them together, and you get that high. Okay? Betty Ford, in her worst, we did not know. How many people remember Betty Ford? Okay, that's better. Okay. As First Lady, she was the perfect First Lady. We saw her as a model for how women should be in relationship with husbands and society and all that. And then one day she announced she's going to rehab. We couldn't believe it because she never looked sick. She never looked drunk. It was she wasn't drinking that much, but it was the combination with the Valium that made her dysfunctional in private. Okay? So here we had a case with somebody who was looking so good, but she was really so sick at the same time. And it was the combination that got her. Liz Taylor was another one. For the most part, anytime we saw Liz Taylor, she looked great. Okay? But it was the combination that got her. So when you're talking about people combining drugs, and in this day and age, they're combining all over the place. And some of it is because of the way the drugs are mixed. These are good examples that you can use when you're dealing with somebody who's abusing cocaine that's laced with fentanyl. It's not just cocaine, it's also fentanyl. So you get a combined effect. It's not the same thing. So when you're doing counseling with people, when you're talking to family members about how bad things are really that they don't see, that's part of what they can, what you can use as an example. Okay. The last thing, dependency and addiction. Okay. Dependency works like this. Sean, you can edit all the erasing that I do too. Just put an overlay of an angel going by. Okay, so dependency works like this. Anytime we take a drug into our system, now this relates to half-life, we take a drug into our system, there's an amount of time it takes for that drug to peak its effect. And then it takes that same amount of time to get out of the system. Okay? So with drug half-life, if it's a 24-hour half-life, that means that 12 hours you peak the effect. So we take a drug into our system, it peaks, and then we get rid of it. Now you know this from a couple of different things. If you've ever taken an antibiotic, the way most antibiotics work today, your first dose you take 2 pills, and then after that you take 1 pill every X number of hours or every day, depending on the product. So this is the way it works. You take the first dose and you try to get up to this point. Because what you're trying to do is kill the organism that the antibiotic is going after. And in order to do that, you have to give enough of the medication over a series of days, usually 5 to 10 days, that's going to kill the organism. So the first dose is that high dose, and then every day after that you're taking 1 dose so that this line is not really going down. So what's happening is so that you're maintaining this level of the antibiotic. The reason they tell you to keep taking it even when you're feeling better is if you stop taking it too soon, it doesn't kill the organism, and the organism will mutate into another form. So you got to kill it. That's why they say you take it for the full prescription, even when you're feeling good, because that's the way it gets killed. Okay? So that's one thing that you know about. Another thing is, a lot of people have misunderstandings about vitamins. You've heard about high vitamin treatment for all kinds of things, from cancers to whatever. And the reality is, every vitamin, we have a limit in our system, at which point we take the vitamin into our system, but our body will only hold a certain level. Everything else gets flushed out in the urine. If you've ever taken very high doses of vitamin B or C, if you take more than's recommended, when you do go to the bathroom, you will know that you took much more than you need because of the color of the urine or the smell of the urine. Because the body is flushing it out, it's not really using it. With chemical dependency, we have the same thing. With chemical dependency, we're taking the drugs into the system, and the way it works is when you keep taking the next dose, you get up to a point where it parallels out. The body will just get rid of the extra. Now, this is the principle behind methadone maintenance. With methadone maintenance, you get to the point where you're on the maintenance dose. Now, when you're first being induced into the methadone, or inducted, you're not safe to drive. You got to wait till you've got that maintenance dose. Once you're on maintenance and not abusing other drugs, you can safely drive. You can safely run bulldozers. You can safely fly airplanes. You can safely do surgery. I've had people do this. And they're safe to do it so long as it's the maintenance dose, because at the maintenance dose, your normal abilities are in full swing. You're not impaired. You're only impaired with methadone, for example, when you're being induced or when you're coming off of it too quickly. And methadone you have to come off very, very slowly. Or if you're using another drug during it. That's when you're impaired. Okay? So dependency is the concept of when you're drinking just enough to be functional, safe, and not a danger to others. Now, what is one of the things that we hear about a lot with this? If you've ever heard the word a functional alcoholic, a functional alcoholic is somebody who's drinking a lot, but the addiction hasn't necessarily kicked in. They're still drinking a lot, but if they stop drinking, they're going to go into withdrawal. Okay? So they're functional, they hold their job, they do all the things they need to do, but they're drinking a lot. Now that drinking may be not as helpful to family relationships as it should, but they're able to function well. They're bringing home the paycheck and all that sort of thing. Stop drinking, and you go into withdrawal, and then you got a problem. Now, one of the places where we saw this happening, which gave us a big insight into a whole lot of things, it used to be, and again, with the exception of Charlie and maybe somebody in the back, ether was the way we were put under for surgery. Ether was a gas. It was kind of a form of alcohol. And you would go under with ether. The bad thing about ether was when you came up out of the anesthesia, you were nauseous, throwing up, all that sort of thing. Similar to a hangover, a bad hangover. Then, during the 70s, they started coming up with these narcotic anesthetics. Now, it used to be that when you were going in for surgery for 24 hours, they didn't want you eating anything. Why? Because when you woke up from the anesthesia, they didn't want you throwing up on the hospital floor. Okay? So they just had you have liquids. So when you came out of the ether, if you threw up, it was relatively neat. Okay? When they came up with the artificial anesthetics, with the narcotics, they didn't have the same issue. So they still kept you on a liquid diet, but you could have a few semi-liquid things, the Jell-O and the ice cream and that sort of thing. In Italy, they had a major problem. In the US and a lot of Europe, they would say, liquid diet, no alcohol. And that was okay. In Italy, that was a problem. Because in Italy, alcohol is part of diet. So the thought of abstinence from alcohol in Italy doesn't make any sense. Okay? They have a real difficult time with that. So when they started using the narcotic anesthetics, they didn't say, stop drinking. Here's what happened. They started using the narcotic anesthetics, had the surgery. When you're in surgery, for a day or two, you're really not in the mood for eating much anyway, and you may have tubes in you and all that sort of thing. What they found in Italy is after 3 days, people started going into DTs because they had 3 days of no alcohol, and that's when DTs can start. And they started having a rush on DTs. So they then had to start using other medications to prevent the DTs from coming on. But that's kind of where we saw that happening. So that was the dependency thing, okay? So you can be dependent on a drug without being addicted. So what's the difference with addiction? Timeline. This is the stage I'm going to skip some stuff. This is a stage, this is pre-addiction. This is when we use too much of our alcohol, we use too many drugs, we smoke too much, we're out of shape weight-wise and all that sort of thing, doing all the wrong kinds of things. At some point, we cross an invisible line. That invisible line is the beginning of addictive disease. We go from not being addicted to being addicted. In the early stages of addiction, the patient does not know that they're addicted. You say to a person in early stages of alcoholism, you got an alcohol problem? No, not me. I've been drinking like this my whole life, never had a problem. And the reason is because their pre-addiction stage is very similar to the early stage. They don't see the difference. People around them, family, friends, coworkers, may start to see the difference, but they don't. So something happens, the first crisis which gets them into treatment. They go into treatment, and treatment for addiction is basically this: abstain from the drug of abuse, get into a good physiological lifestyle, good diet, nutrition, and exercise, get into a good social and spiritual lifestyle, stick to that, you're in what we call remission. Now, in our field, we tend to call it recovery, but in terms of other diseases, it's remission. At which point, especially for simple addicts, you function normally. If you return to the drug of abuse within a relatively short period of time, the addict will be using more drugs than they were when they stopped. Now, most people would think, if I'm clean and sober for a couple of years, if I start using again, it's like starting all over again, but that's not what happens. And you'll hear this among recovering people who relapse. When you start using again within a relatively short period of time, you're using more than when you stopped. And the concept is this: even though you're doing well, the disease is still progressing. And the reason is addictive disease is a progressive and chronic disease. By progressive, we mean that once it starts, it always goes from a lesser degree to a greater degree. And by chronic, we mean the only time the disease ends is when the person dies. Now, last year, somebody found us wrong on that. Addictive disease does not stop when you die. The addiction in the brain continues for about 3 days after you die. Even though there's brain death, the addiction piece still hasn't detoxed out of the brain. Don't tell me why these Swiss scientists were digging up dead alcoholics to cut their brains apart, but that's what they found, okay? So I used to say, you're gonna have this disease till the day you die. Now I say, or for another 3 days, okay? It's not something you're gonna get over very quickly, okay? So that's it, and then people get into treatment again, and this is why many people with addictive disease have relapses early on, and then eventually will get into long-term recovery. Any quick questions on that? Because this is the time frame that we were hoping to stick to. Okay, so thank you for listening. The handouts that you have, the people that are going to be watching this via distance learning will be given access to the handouts so they can make their own notes as they go through it. And let's take a 10-minute break, and then we'll come in for session 2. Okay, thanks.